have all their monitors on. So like I said, EKG, blood pressure, and pulse ox.
So we're gonna start. We're gonna pre-oxygenate the patient. So what pre-oxygenation means? What are we breathing in room air right now? Does anybody know how much oxygen is in room air?
Like 20%.
21%. Very good. When we are intubating the patient, we want them to breathe in 100% oxygen. We're going to take over breathing for them. When we take over breathing for them, we want to give ourselves as much time as possible to get that breathing to them. How do we do that? We bring up their oxygen concentration. So the first thing we're doing is pre-oxygenating, right? He's got that mask on. We've got oxygen over here on the machine. That's that green line, that green dial there. Also in this operating room, if we had to, right? If we had to in an emergency situation, we could do surgery in this room. Pushing some medications that we typically give for induction. So listen up so you can hear what the different medications are.
Okay, so this is Versed. We normally give this in pre-op before it's kind of like happy juice. So normally it'll just relax the patient. And normally this is given in pre-op. So I'm just gonna give 2 milligrams of this.
And so there's barcodes on those syringes. So over here on the machine, I'm able to see, okay, what she just gave.
Yep.
And then the Mediman, he will react according to what drugs are there.
Okay, and then I'm gonna give fentanyl after the Versed. This is the first thing you give when you come into the OR.
Pain medication.
Pain medication, if you didn't know.
Yep. So we're giving a relaxant medication, something to kind of ease the anxiety.
You get a view of this, like.
We're giving pain medication, something to kind of blunt the pain from what us Dr. Prison is breathing to.
Okay, and now I'm gonna give lidocaine.
Okay,
So
go ahead. No,
So
go ahead.
the propofol, which is our main induction agent that we're going to use for this patient, stings really bad through the IV when you give it. So we give the lidocaine to kind of blunt that pain stimulus.
I'm gonna give our main induction agent, which is propofol, and that'll help the patient go off to sleep.
And so this is where pre-oxygenation is important because after this bolus of propofol, they're going to be apneic. They're not going to be breathing. So.
Right. Apnea means not breathing.
So we're gonna make sure that they're asleep. We're gonna do an eyelash reflex. We're gonna make sure their eyelashes won't move when you touch them. And then you can also like ask the patient if how they're feeling, and if they don't respond to you, you know they're asleep. So then we're going to breathe for the patient because at this point they're not breathing. And you can see that on your end tidal, you're not getting any end tidal.
Right, you see the end tidal is 0. There's nothing coming out because the patient isn't breathing anything off.
So now I'm gonna breathe for the patient. So we're gonna add a little bit of pressure support, and I'm gonna give breaths for the patient. And you wanna look at your tidal volumes and your end tidal CO2 to make sure that you're breathing for the patient.
So on a real patient, you would see fog in the mask, right? Because it's breathing off, right? It's hot air. You would see end tidal, you see you're getting a waveform there, and she's off. What she means by tidal volume is the volume that she's now pushing into the patient, positive pressure ventilation. So now she has taken over the patient's breathing completely. If she doesn't squeeze that bag, the patient is not breathing. The patient is apnea.
And then I'm gonna give the muscle relaxant to help the vocal cords open up so then you can stick the tube through the vocal cords into the trachea to help the patient breathe. Giving rocuronium, which is a muscle relaxant, to help open up the vocal cords.
Again, the machine, it just goes based off of the medications that you give. If a real patient, maybe the blood pressure does drop because of the propofol that you give.
Yep.
So then she knows that right now that she's going to be able to handle it, or she's going to intubate the patient, so that will go up.
So,
All right, so let's say it's been your 60 to 90 seconds.
So you normally wait 60 to 90 seconds for the muscle relaxant to kick in before you can intubate. And then we're gonna set this to the side.
All right, so we're going to use the glide scope so all of you can see what it actually looks like. We don't always use a video scope. Sometimes we just use just a regular handle that I can pass around and show you.
So normally you would
Turn that screen so they can.
open the mouth
Yeah, I
up.
was just gonna let Mia get a view and then I'll turn.
So what she's doing is she's taking the blade into the mouth, and she wants to get a view of the vocal cords so she can pass the tube through the vocal cords. I want to go through the vocal cords into the trachea, and so we can breathe for both lungs.
Yeah, you'll see
Now
it.
she's going to put the tube in there.
Sorry, Mia, I'm making this
Yep.
difficult.
So it's through the vocal cords. Now we're gonna ask to pull the stylet, and we'll advance slightly more. So we're gonna inflate the cuff on the endotracheal tube, and then we're gonna make sure that we're in the right spot. So we're gonna give a few breaths while we listen to the breath sounds. We're gonna make sure that the breath sounds are bilateral and equal, and that we don't hear anything in the stomach, because you don't want the tube in the stomach, right?
Look, we're getting end tidal now too.
Yep.
See that we got the waveform back? So now we are breathing for the patient.
Yep. Make sure you listen to their breath sounds, and then we can go ahead and turn them onto the ventilator.
Those drugs we gave in the IV, they only last for a period of time, right? So to keep the patient asleep, we also give the anesthesia gas, sevoflurane, isoflurane. That keeps the patient asleep. So we're monitoring how much gas you're getting, we're monitoring how much fluids you're getting, we're monitoring all your vital signs, we're giving pain medication, and then near the end of surgery, we're also gonna give some anti-nausea meds and wake the patient up.